Good evening, everyone. I'm Dr. Gauri from Medanta, Medicity, Gurgaon, and today we'll be discussing about this journal from Indian perspective and our own version. So, to start with, can everybody see the screen and the change?
Yeah.
Okay. Thank you. So to go briefly about the background, so the presence of cell-free DNA in circulation was first described over 6 decades ago by Mandel and Matthias in 1948. That was about 3 years before the double helix discovery. So now why is it important? So it's been known since then, and it's been used in other facets like in cancer and in other transplants such as liver and heart. So why now? Why for renal transplant? Basically, in transplant medicine, the presence of donor-derived DNA in the recipient sample or urine, it's called chimerism. So it's a microchimerism, and its use as a measure of transplant injury has been about just recently being tested and found out that it is quite effective in the clinical trials. So what is it? What is this entity? So it exists as a double-stranded, non-cell associated DNA fragments residing in the recipient's blood, and it also can be found out in the urine, that is, it is shed in the urine. So these DNA fragments are approximately 150 to 180 base pairs in length, which would indicate that the source of these fragments is apoptosis. Now, there are larger DNA segments as well, up to 21 kilo base pairs, which occur in patients and most likely are result of necrosis. Now, what's important is the median half-life of this cell-free DNA, which is about 30 minutes to 2 hours. Now, this is important. As we discuss further, we'll come to know. So this is a rough diagram. This over here is the graft kidney, and we have the necrotic graft cell and apoptotic graft cell, as we can see. And in the circulation, we can see labeled as red, donor-derived cell-free DNA. And in blue, we have recipient-derived cell-free DNA. And there are the apoptotic blood cells. So these are cleaved by the nucleosomes, and we can see the graft portion of both the donor and the recipient derived cell-free DNA. So it exists as trimmed, meaning it exists in multiple forms in the form of base pairs. So we were talking about 120 to 150 base pairs, which is normally found in circulation, which we are looking after and detecting. Sorry, yeah. So what is the rationale for use of this quantitative so-called biomarker? So it's called liquid biopsy, as we say, in which transplantation, it's based on the fact that organ transplants are also genome transplants, which open up the possibility to use them to directly monitor allograft health. So to study this matter, we'll go briefly and see a few other trials which were first initiated on this premise. So we have the Sentinel trial, which is the DART study, Bloom et al., which was published in Journal of American Society of Nephrology in 2017, in which they reported use of donor-derived cell-free DNA in transplant recipients, which was measured by the targeted next-generation sequencing assay. Here, I would like to add, so previously, meaning after the 1990s, whatever cell-free DNA was there, so there was a dilemma or a doubt as to how to detect this DNA in the recipient, which is donor-derived. So they could do it only in the different sex transplants. If a female was a recipient and male was the donor, so they used to detect and tag the Y chromosome, which was there in the female in the form of the graft. So only opposite sex identification of the cell-free DNA was possible. Now, later on, after so many decades, we have the PCR, droplet PCR and targeted NGS, next generation sequencing, which makes it easier to detect this DNA in the blood to do sort of a quantitative analysis. So now what is this DART study? Diagnosing acute rejection in kidney transplant recipients. So as I said, it was a Sentinel study in 2017. So it used the AlloSure test. Now this is a targeted method for DNA capture. So there are two methods. One is the random method and the other is the targeted method. This uses next generation sequencing. An important point is it does not require the donor blood. It is just based on the recipient's blood. So we just have to take one sample, that is the recipient sample. So this was a prospective multi-centered trial which involved almost 384 patients, out of which, after ruling out, 102 patients underwent 107 biopsies, which were analyzed in the data. And what did they find? They found out that the area under curve for any rejection, the discriminatory factor for any rejection, for that the area under curve was around 0.74. And this area under curve was even more precise if we considered antibody-mediated rejection. So in samples without ABMR and with ABMR, if we compare, the area under curve ROC for discriminating them was even more precise. And what more important is, it had a sensitivity and specificity of 81 and 83% respectively. And the negative predictive value also improved if we narrowed the or categorized the substrata into ABMR. So the negative predictive value for any rejection is around 84. But if we consider only ABMR, it is 96. This is quite a significant value. And also they found out that the median donor-derived cell-free DNA, the percentage which they found out was 1.6. And for the control group, which was the non-rejection group, it was 0.3. And it was around 1.2 for T-cell mediated rejection and 2.9 for ABMR. So basically what DART study showed that in all the rejections, especially ABMR, can be certainly put out with the such high levels. And a discriminatory value of 1% was the set level beyond which we could determine whether yes or no the patient has rejection or not. So 1% was the value set. Then we move on. Next was the Admiral trial. This was carried out again in US with 1,092 patients and almost 219 biopsies. And it was published in 2021 by Bu et al. And what did it show? So there was a little twist in this trial, in the sense they thought that what else could this data provide? Apart from the fact that it shows rejection. So it can show whether it can show the graph decline over a period. How will we quantify that? In the form of eGFR decline. And whether there was a temporal relationship between the formation of de novo donor specific antibodies and precisely the level of donor-derived cell-free DNA. So these two were the extra parameters which they focused on. And also this was a prolonged study. So patients were followed up for a period of 3 years. So what did they find? So they found out that persistently elevated. So again, the cutoff value they took from the previous studies as 0.5 and greater than 1. So above 0.5, percent if you have, then this predicted a greater than 25% decline in eGFR over a period of 3 years. And also, if the donor-derived cell-free DNA, this is on repeated monitoring, if it is greater than 0.5%, it was associated with 3-fold increase in the risk of de novo DSA. That is quite significant. And also the area under curve for this study was around 0.80. That was also significant. So it sort of broadened the utility of donor-derived cell-free DNA, not just restricting it to rejection, but also to finding out whether it is a potent marker for GFR decline, graph deterioration in the form of de novo DSA formation. And what is important from this study is the changes in the serum creatinine succeeded the changes in donor-derived cell-free DNA. So it's a great thing that we beforehand have an idea that, okay, the serum creatinine would likely rise. We have a rising level of donor-derived cell-free DNA on repeated samples as this last. So basically a form of subclinical rejection. So now, after discussion of all these trials, let's come on to today's topic of discussion, which is donor-derived cell-free DNA and active rejection in renal allografts by Dr. Edwin Fernando, sir. And Department of Nephrology, Government Stanley Medical College. Yeah. So we'll discuss about this. So why was the need for the study? So we have already discussed, we have so much international data. So we need something from our side. Improvement of personalized immunosuppression is necessary in kidney transplantation to reduce premature graft loss. And as we discussed earlier, and now we know, non-invasive donor-derived cell-free DNA has a great potential to detect graft injury or rejection. So the utility of this has not so far been studied in an Indian setting. All the previous studies which were discussed before had patients of UNOS, and both Admiral study and the DART study had one thing in common, that they had more deceased donor transplants and more Black population, and all were from the USA UNOS registry for renal transplants. So we needed some data from our setting, that hence the study. What was the aim of the study now? So basically, we wanted a quantitative interpretation, whether we can, from a certain threshold of donor-derived cell-free DNA, diagnose allograft rejection and determine whether it can discriminate between stable graft function, active rejection, and non-rejection pathologies. Now, if we talk about non-rejection pathologies, one thing which I would like to add, which I forgot, that in the DART study, there was one case of the patient having BK virus, around 9.9 million copies, and that person had high level of threshold of donor-derived cell-free DNA, which was in the range for the rejection. So that was one limitation, or we can say that needs more investigation, whether BKV can also affect the graft in the same way as rejection, whether DD cell-free DNA would be able to differentiate both. We'll discuss this later. So this was the aim of our study. What was how was the study designed? A convenient sample size of 31 was chosen. This was a prospective pilot observational study in the Department of Nephrology, Tamil Nadu, India. Now, what was the inclusion criteria? So live related renal transplant recipients who presented with graft dysfunction and have been planned for a graft biopsy as per the unit protocol were included. Now, stable graft dysfunction was defined as creatinine within 10% of the best creatinine and no proteinuria for the preceding 12 months. They were also included because we need controls as well. And exclusion was no patient within 2 weeks of transplant or any surgical intervention were included, because any surgical intervention would again supposedly provoke the release of cell-free DNA, and that would mask our findings. So we needed because post-transplantation, these values peak after 2 weeks and then subside. So we would like to exclude that from our criteria. Yes. So what is the methodology? This is very important because this was one of its kind which was conducted. So we'll discuss this briefly. So 10 milliliters of venous blood was drawn for estimating donor-derived cell-free DNA levels before graft biopsy or 24 hours after the biopsy. So as we discussed earlier, the DNA had a half-life of 30 minutes to 2 hours basically. So we required that we take the sample just before the biopsy, before there would be an apparent rise because we are doing the intervention, or 24 hours after the biopsy when the levels, if they have risen, would already be subsided, most likely. In previous studies, they have kept a 12-hour window, but in ours, we preferred a 24-hour window to be just more precise. So all samples were stored in specialized cell-free DNA preserving tubes. These were called the PAX gene tubes, and temperature maintained at 4 degrees Celsius. Now, the donor's blood samples that have been preserved at the time of transplant were utilized. In the absence of the same, 2 ml donor blood was freshly collected for the identification of donor DNA signatures. Now, we needed this in our study. So all recipients also provided a buccal and saliva swab sample. The total cell-free DNA was extracted. The method was and the technology was from Duren, Germany. Now, the donor-specific DNA marker was identified by screening of peripheral blood obtained from donor and recipient from an Indian population specific polymorphism pool, because we need those SNPs. So for that, we chose the specific Indian polymorphism pool. This was developed by Enable Biolabs India. Recipient-specific markers from buccal swabs were analyzed. Quantification was performed by comparison of percentage amplification of donor-specific DNA markers in the cell-free DNA fraction with standard graph and was expressed as nanograms per microliter. Now, to the right is a image inset we can see. So the marked in that box, which is highlighted in red, is we see in the top level donor specific DNA. Now, if we see that black kind of mark in the number 5 area, SNP marker, single nucleotide polymorphism marker. Now, that is meaning respectively absent in the recipient area. So that is how the sort of identification works. What was the primary outcome of our study? So diagnostic accuracy of donor-derived cell-free DNA as a marker of rejection was studied. That was our primary aim, just to find out whether it is or it isn't a marker of rejection. Statistical analysis was the social sciences SPSS software were used for analysis. Sensitivity, specificity, positive and negative predictive values were analyzed. The receiver operating characteristic of analysis was performed to assess the discriminatory ability, which is the most important thing which we will do. P-value less than 0.05 was considered significant. So now what were the demographics of the study? So there were total 31 patients as we discussed. So in the active rejection group, they were 12. In the no rejection group, they were 19. Males were respectively, as we see, 60 and 73%. The mean age was also well balanced. Time cis transplant was 814 for the active group, and the no rejection group, it was 649. The mean creatinine levels were also somewhat well matched. So were the rest of the parameters. Now, how was the case distribution among the diagnostic criteria? So patients with stable graft function were 11. Patients with active rejection were 4 in both ABMR and T-cell mediated rejection, and only T-cell mediated rejection were 8. So there were total 12 patients with active rejection, and rest of the 8 were with non-rejection graft dysfunction, which were acute pyelonephritis, CNI toxicity, or acute tubular injury with IFTA. So this is a graph which shows in quantitative levels, which is calculation of donor-derived cell-free DNA in nanogram per ml of all the study participants which were there. So as towards the left, we see clustering of those levels. Why we see the clustering to the left is because all the rejection patients are there. There is ABMR, TCR1B. So we see a lot of clustering towards the left side. And towards the right, we have mostly stable patients. There are some outliers which we will discuss. Now coming to this graph. So this was the quantitative analysis. And the next one, this was the percentage of donor-derived cell-free DNA to the total cell-free DNA. So this, after we converted into a fractional ratio, the sort of discriminatory value improved. We can see 3 outliers in this table. One is the stable to the rightmost with 1.88 as the percentage value, and one with ATI IFTA as 1.11, and one T-cell mediated rejection category 1A as 3.33. Now, if we keep these aside for a moment, now we'll respectively go into the rejection part. So we see the ABMR column. So the the threshold level which we can say for ABMR was 0.25, ranging up to 1 in our study. And for TCR1B, it was from 0.06 to 0.02 as correctly shown in the diagram. And for those who were stable patients, it was almost less than 0.06 or less than 0.2 if we consider the ATI and pyelonephritis as well, including them. So now we'll see the table for any rejection, no rejection, quantified as a yes-no test. So what was the sensitivity and specificity? So if we just calculate the amount of patients having any rejection versus no rejection and formulate a table out of it, and we calculate the sensitivity and specificity, it would be 75 and 68 respectively. Now, what important is, in the further coming tables, we will see a change, particularly in the NPV, negative predictive value, which we will see. The sort of the precision for that will go on increasing as we see. So here there are two tables. The topmost is for ABMR in the form of yes and no test. And the sensitivity is obviously increased, which is about 100. And the negative predictive value is also 100. So it is quite significant. And if we consider the next table for donor-derived cell-free DNA and ABMR alone, the negative predictive value is consistent with it being 100, as well as the sensitivity, and the specificity is slightly increased. Now, if we consider at a threshold of 0.25 cutoff, again, we have a consistent result of a negative predictive value being 100 with sensitivity of 100 and specificity of 88. And if we take the entire donor-derived cell-free DNA at 0.05 cutoff to predict any rejection, then we have a little bit lesser sensitivity and specificity of 66 and 73. So this means that if we categorize it or consider only ABMR, the precision is quite improved, meaning the data shows almost sensitivity of 100 and negative predictive value of 100. Now, at 0.05 cutoff to predict whether TCR1B or ABMR, again, it is showing consistent results with specificity of 75, sensitivity of 100, and negative predictive value of 100. So the results are consistent if we consider higher stages of rejection, that is TCR1B or ABMR. This figure shows an important value of 0.889, which was derived from this study, which is definitely significant, the curve from the study. Shall I go ahead with discussion?
Yes, please go ahead.
Yes, sir. So here are the 7 trials which have been conducted in the past recent years from 2017 to 2020 with their threshold for donor-derived cell-free DNA and the receiver operative characteristics area under curve. So the mean of the ROC AUC is 0.81 over here. So all these studies, Bloom et al., Sigdal et al., Olerich, Huang et al., Zhang et al., have been consistent with the same results, proving that there is improved negative predictive value, as we can see, which is shaded in yellow, and sensitivity and specificity both are almost in the same range. And they one important thing is they have derived a threshold for detection of donor-derived cell-free DNA, which can be used as a basis for further studies if we use the same method of calculation which they did. So we will get similar results likely. So all these studies basically proved the fact that in fact donor-derived cell-free DNA did differentiate or discriminate between active rejection versus no rejection. One thing common in all of these most likely was that ABMR could be almost with great amount of certainty stated that, okay, this is rejection. There was some difficulty, however, with T-cell mediated rejection class 1A versus 1B, with as the progression of rejection, the results were more better and more consistent. There were some confounding issues with patients with BKV virus showing greater thresholds of DNA, or there were some outliers as well in which there was significant IFTA and ATI showing greater amount of cell-free DNA. So all those need to be evaluated as well. But the consistent level of ROC AUC being 0.8 was quite significant in all these studies. So what do we learn from all this? That monitoring of donor-derived cell-free DNA may be also may be helpful to guide immunosuppression minimization. Now, one more important thing was in Ulrich et al., they found that increased donor-derived cell-free values were associated with subtherapeutic tacrolimus concentrations after kidney transplantation in patients with variable tacrolimus levels. Therefore, this donor-derived cell-free DNA might be helpful to detect subclinical graft damage caused by immune activation due to immunosuppression. These were the findings particularly of the Ulrich et al. Study published in 2022. Now, donor-derived cell-free DNA performs best in ruling out ABMR, as we discussed earlier, and higher grades of TCMR1B. It performs rather poorly in discriminating lower grades of TCMR. Most promising among all the studies, as we discussed, was the negative predictive value of 100% for TCR1B plus ABMR. And it was 100% for ABMR alone, and overall 81% for any form of rejection. So it is conceivable that significant IFTA and ATI heightens the output of donor-derived cell-free DNA from the chronically injured graft, because as I said, that was one outlier. This was the likely explanation which I found from the data. Despite the lower sensitivity of DNA detection, it is inherent that our analysis seems to perform comparably well. I can say that in detecting higher grades of rejection. In this pilot study, we demonstrate the diagnostic accuracy of donor-derived cell-free DNA in predicting rejection of renal allograft. Now, it performs well in ABMR and higher grades of T-cell-mediated rejection, but poorly in lower grades. This is the first of its kind study reported in India. Now, our thresholds for detection of donor-derived cell-free DNA are obviously different from those published in those studies due to cost constraints, but it still performs comparably well across various pathologies. The total concentration of donor-derived cell-free DNA has lower diagnostic accuracy for rejection than its percentage to total cell-free DNA in our study. This was similar in other studies as well, likely that the discriminatory value increased once we took it as a fraction of DD cell-free DNA upon total cell-free DNA. Now, its role in surveillance needs to be investigated more, as it fails to detect early rejections accurately. Thank you.
Thank you, Dr. Gauri, for a wonderful presentation. I think we all will agree that a non-invasive marker and also reliable marker is something which we'll always be happy to have with, and having data from India always helps us. Now I request our panelists, Dr. Agrawal sir and Dr. Narayan Prasad sir, to initiate the discussion. We also have with us the authors, the article authors who can be asked queries.
So thank you, Aruna. Can I ask few questions?
Yes, sir.
Yes, Narayan, go ahead.
Yeah, please. So thank you, sir. Basically, we have a literature and evidences are there, and there are few other parameters which can increase this donor-derived cell-free DNA. Like you have pointed out in some of the studies, like sometimes even urinary tract infections, hemodynamic instability, and sometimes surgical manipulations. So how this has been taken care? So that is the one question for Edwin. Definitely. So that remains always. And there was one outlier in the control group, and that has very high levels of the donor-derived cell-free DNA. So that was another concern, whether what was the reason of this, whether this CNI has been tested. Sometimes even ATN can be there in some of the patients which can have the rise in the cell-free DNA. One of the basic science studies, or one of the studies, has shown that as you decreasing CNI level, the cell-free DNA were going up, and subsequently some of the patients develop unstable graft or some kind of the early graft dysfunctions happens. So impact of CNI on cell-free DNA is also always remains a concern. So there are multiple co-founders can be there. There was one question in this, how you differentiate between recipients and donor derived DNA. So there is definitely deletion, insertion, polymorphism is there. So you can search out from the literatures that helps in differentiating whether deletion, insertion, polymorphisms or the donor from the recipient's DNA. So that you can go in details later on for this one question answer in the chat box. So just Dr. Irvina, so there are many confounders and definitely this was good efforts. I would like to congratulate you and your team for taking these initiatives. Number is really limited, so we cannot come on the conclusions of anything in the for the even for the Indian settings. But definitely literature evidences are very strong to suggest that particularly for the ABMR, the negative predictive values is very high. So that is always useful. So your comment.
Yeah, thank you, Narayan, and very well presented by Gauri with the excellent review of literature.
Thank you, sir.
I agree with you, Narayan, that there are a lot of confounding factors, and we have tried our best to remove these confounding factors or remove those particular subjects where these confounding factors could have influenced the, the results. So, to the best of our knowledge, the issues that you mentioned, the confounding factors, have all been removed, and only the ones that we found that were genuinely showing up on those SNPs, only those we have taken. We understand that this is a pilot study, and I'm sure there are other people who are working on this who would better this study and then come out with more data from our country. And as Darshan mentioned in the beginning, I think a multi-centric study on this involving patients from all parts of the country would throw more light and more robust Indian data on this before we take it forward as something like an allosure, looking at a non-invasive way of picking up rejection quite early. Regarding the technical aspect of the study, I think if Dr. Arvind has joined, he could highlight a little more because he was a man behind all these technical aspects of looking at it. Arvind, are you around? Dr. Arvind?
He was there.
Ah.
I think he was there, but he's not been added as a panelist, so he may not be able to speak, sir.
No, I have
Harsha,
seen him in the
can
We
panelist.
added him as a panelist sometime back.
Yes.
In the meantime,
Harsha, can you supplement?
yes, sir.
Okay.
Hi, everybody.
I think Dr.
Good evening.
Arvind is in there.
Arvind is here.
Yeah,
So,
he's here.
Please
Arvind,
add.
you are audible. You can go ahead.
Yeah, Harsha, go on.
So hi. So regarding what Professor Narayan Prasad asked us about CNIs. So if you look at it, 3 of our acute tubular injury patients actually had CNI toxicity, which we presumed because of single myocyte necrosis and isometric vascularizations. We attributed the ATI to be because of CNI toxicity. And in them, 2 of them showed negative, non-detectable donor-derived cell-free DNA. One of them had a low level of donor-derived cell-free DNA. So I know the sample size is very small, but of the 3 patients, they were below the cutoff that we are putting forth for saying it could be active rejection. So that is one thing that I just wanted to add on as far as what Narayan Prasad sir asked about CNI toxicity and possibility. But I think the underlying theme, even from the latest studies, is that donor-derived cell-free DNA is a marker of graft injury. So it should be taken as a marker of graft injury. And we think that when there is active rejection, the injury is so severe that it is quite at much higher levels, and that's why we're able to predict rejection. But again, even if you look at our study, if you look at the positive predictive value, even for a cutoff of 0.25%, the positive predictive value, even for ABMR, is quite poor. It's only about 55%. So I think our conclusion has always been that it is a good rule out test rather than a test to say that this is rejection. So having a very 50% positive predictive value suggests that it could be rejection, it need not be rejection. But I think in a clinical situation where we are not able to do a biopsy and you want to strongly rule out ABMR, I think it really helps. The other point about surveillance, that's what we also want to look at. Can it be used for post-transplant surveillance? But if it's going to not detect lower grades of TCMR, if it's not going to detect early rejection, then using it as a tool of surveillance is not going to be actually possible, because you're only going to detect it when the injury is quite severe. So at this point in time, even in the Western data, they still feel that borderline TCMR and early TCMRs are still missed out, or they are at the a much lower value of donor-derived cell-free DNA. So you're still not going to be able to pick up early rejections. So to use it as a surveillance tool, even if you use an NGS platform, at this point in time, I don't think the data is suggesting that we can use it in that way. And sir already said, our data, we started collecting this data in 2018, presented it in Southern Chapter in 2020. So it's almost 5 years since we started generating this data. And the world has actually moved on. If you look at the trifecta study, which has come out last year by Dr. Halloran's group, their gold standards for rejection has changed. So here we are comparing it to histological rejection. But the trifecta study suggests that donor-derived cell-free DNA is actually best correlating with molecular markers of rejection. And we should, if we are critically analyzing our paper, the world has moved on to where they are diagnosing rejection even better. So therefore, donor-derived cell-free DNA has been shown to correlate with molecular signs of rejection. But are we at a stage clinically where we are going to treat molecular markers of rejection? I don't know. So that part of it still has to evolve.
Okay,
And
Dr.
the trifecta study also showed correlation between cell-free DNA and the DSAs.
Yes, sir.
Of course, DSA is something that's doable in our country,
Yes.
though we can't do the molecular markers straight away right now. So probably a study looking at combining the diagnostic utility of DSA and the cell-free DNA would be much more sensitive in picking up an early rejection.
Yes, sir. Yes, sir. Definitely.
Dr.
Arvind, your comments. Arvind?
Oh, yeah.
आगे आगे चलते हैं, तैयार हो
Can
गए?
you?
Yeah.
Okay. All right. So, as Dr. Harsha
okay.
mentioned, any injury, like even a biopsy needle, can immediately release the cell-free DNA into the bloodstream. So any injury, even infections, now we have seen that in several cases of lung transplants and even heart transplants with CMV infection, the cell-free DNA level goes up tremendously. So cell-free DNA it is a very good marker. I also agree with that, but it goes up in many conditions, including the infections, and sometimes if there is a stent and there is a dislodging of stent, that also releases the cell-free DNA. So the cell-free DNA is a good marker, provided if you are able to rule out all the other factors. If you're just going to focus only on the the clinical symptoms and its association with the cell-free DNA, probably it's a very good marker. But there are other ways to confirm the rejection, which is the cell-free RNA that I have invented. Now, the cell-free RNA is very different from cell-free DNA because, as I forgot the name, the presenter mentioned, the half-life of the cell-free DNA is very short. It's actually in few minutes, like probably in seconds, actually. So the half-life is very, very short. But in case of cell-free RNA, the half-life is a little bit longer than the DNA, and importantly, it is released only during the rejection event. It is not released during infections. So this we have confirmed in the heart and lung transplant patients, where in patients with infections, the cell-free DNA goes up, but cell-free RNA remains stable.
Dr. Arvind,
Yeah.
I think we should restrict to the journal which has been presented rather
Yeah.
than going to the theory. So,
Okay.
I would request Dr. Shyam was raising hand. Before I comment, Dr. Shyam, please go ahead.
Yeah, thank you. No, I just had a couple of questions. So even if you have the one thing I was looking, although the numbers are less, that the sensitivity is quite low, and many patients with rejection, they don't have higher values. And again, the values are actually, even if they have taken a value of 0.25, usually they take 0.5 or more. And second of one was that how you are going to treat, even you have higher range 0.5 or 1, how you are going to treat without actually knowing what is going inside the kidney, what is the chronicity, what is the activity, whether it is the T cell mediated or antibody mediated rejection. So that's are the important questions. You need to do a kidney biopsy in any case.
Yes,
Your
agreed.
comment.
Yes, that is true, sir.
Yes,
If you
true.
see the cell-free DNA is a good marker for the surveillance. If you see an elevation in the cell-free DNA, then it is time to do a biopsy, because cell-free DNA by itself will not differentiate between the T cell mediated and antibody mediated rejection. You're right. So we have to, it is, probably it says that we have to go ahead for biopsy.
But it
Sir,
is
and regarding to your
actually
question
do
with the cutoffs,
surveillance even in Indian. See, this costs around 30 to 40,000 in India also, and in that cost you can do a kidney biopsy. So that is the biggest question. How and how frequently you are going to do that?
So cell-free DNA, it costs around 9,000, sir.
No. This is in the government setup might be, but in the private, one of the pathology, it is 30 to 40,000. I think.
No,
sir, I
that
think
is
two things.
altogether different, Dr.
Yeah,
Syam. Cost is
the
for someone, cost is nothing, but that is always important. Is there any value? I just wanted to know that serial monitoring of the cell-free DNA. Is there any importance that it gives you more information?
So two things. I think what Dr. Sham sir was telling about the cutoffs 0.26 and 1, it's inherently different because these are two completely different platforms. Most of the platforms of 1% cutoff are NGS-based platforms. And so the actual cutoff should not be compared between our study and those studies, one. And so therefore, this is a much more primitive platform. But at the same time, we are trying to say that in terms of predicting rejection, it's almost doing the same thing. And that's why I think Dr. Arvind is quoting a lower cost, because it's basically an electrophoresis and a slightly more primitive platform than AlloSure or other commercially available.
Yes.
Is concerned because it does not pick up early rejection, then at this point in time, we cannot say that it's actually going to be useful for surveillance to pick up early rejection, because in surveillance, we want to pick up early rejection. And at least the platform that we have is not going to pick up early rejections. Even in Western data, whatever the platforms they have, it will pick up some level of donor derived DNA, but it will still be at the same quantifiable level, which is similar for a person with acute tubular injury or with pyelonephritis. So even if you're detecting it in AlloSure, you will not be able to differentiate whether it is early TCMR or whether it is pyelonephritis. So at this point in time, donor-derived cell-free DNA cannot probably be used for surveillance unless it's rising above the threshold of 1% in AlloSure or 0.25% in our platform. And second is, definitely it does not replace the need for a biopsy. Biopsy is still what we have to go by. But in those patients where we are not clinically not able to do biopsy, let's say there's some bleeding there, this is some logistical problem, we may be able to use it to rule out ABMR. That's the maximum clinical utility this platform currently gives us.
I would like to comment in two ways. One is Dr. Gauri's presentation. I think because of a senior agent and a general club presentation, some of the point I would like to say about the Dr. Gauri's presentation, and then come to the general and the question to Erwin. First,
Yes.
to Dr. Gauri.
Yes, sir.
I mean, Dr. Gauri, don't take it otherwise. Your introduction was too long for the general club presentation.
Okay, sir.
Normally, general club presentation introduction has to be very short, and we don't go a detailed study, which actually should come into the discussion rather than in introduction.
Okay, sir.
I think you took some 10 or 12 slides for introduction. Second thing is that which usually I see in our residents also, that we usually read from line by line, which should be avoided actually. Slides should be taken just for the help, not for reading the line. And the third most crucial thing is that you were speaking that we did this, we did that. Rather, you were actually narrating somebody else's study.
Yes, sorry,
You
sir.
should say that author did, or in this study, rather than saying that even you are writing also that we demonstrated the diagnostic accuracy. So which looks that it is a copy paste from the journal. So that looks little odd. Now coming to Dr. Irwin, I've got some reservation or some comment on the methodology of and the from a editorial point of view. You see, if you read introduction, it says that the aim was prediction of rejection. Now, the prediction are of two type actually, diagnostic prediction and prognostic prediction. So it should be very clear what we are aiming for prediction. Because if it is prognostic, then there is a time component. Second thing, if I correctly understood that the patient involvement was only one time, patient was not probably followed in terms of a outcome or the treatment protocol. So keeping that in mind, it becomes a cross-sectional study rather than a prospective study. Now the next point is that in a financial disclosure, it was mentioned that no financial disclosure. Now think like cell-free DNA, somebody has to pay. I'm not sure whether patient paid for the test or the hospital paid, but saying that there is no finance involved is not appropriate. Fourth thing is that number of cases are too small in terms of a total cases, and once you do subgrouping like no rejection or CNI or acute pyelonephritis, it becomes one case, three case. So probably I understand that this is a pilot study, so we probably cannot be very strong in concluding out of study. The next point is that I find a little odd in clubbing the stable patient with no rejection. Those two are separate group and should be analyzed separately. Another point is that stable was taken as creatinine less than 1.5, which many of the patient with 1.4 or 1.3 may not have a normal graph. They might have a stable graph, but it may not be normal. And once we know that the cell-free DNA can be increased in at least in your study also, one patient with IFTA cell-free DNA was high. So saying a stable patient in this type of a study where the biomarker is increased in chronic stage also will be misleading if we mix no rejection or other causes of graft dysfunction with a stable graft. So these are the issue which probably must be the reason, I don't remember now, must be the reason that the article took a very long time in getting reviewed and published. Another minor point is that just for senior resident or for people who write manuscript, now inclusion criteria was all living related transplant. Now, if that is inclusion criteria, then the living related or disease donor shouldn't come into the table. In a demographic table, the living related was 100% in both the columns. So these are the few of the things which I think Edwin needs to answer.
Yes. Thank you, sir. Thank you for those comments. Most of them are very pertinent. Regarding the funding, it was Dr. Arvind who actually undertook the entire job. So the patient did not pay for any of this, just being a public hospital.
No,
Dr. Arvind's laboratory.
what my point was that we should not write that there is no funding involved. Funding has to be Dr. Arvind. I am sure he must not paid from his own pocket. It must be hospital funding. So
No, sir. No,
It
our
would have been
government does not.
better to say that the department funding was, there is no external funding, but saying that no financing was involved is not appropriate for such type of a study.
Dr. Arvind's lab did this out of goodwill.
No,
I'm sure he
Lab
spent.
must be getting funds from somewhere.
No, sir, I have funding from different agencies.
Yeah, that's what I am saying. So it is not financial disclosure doesn't mean that it should be direct funding to the PI.
Besides that, there are so many of the R&D works that goes on in my lab, and many of them, it's the money generated from the lab is reinvested into it.
The other thing about the timing, yes, it was a one-time exposure. It was one-time follow-up, and of course, the follow-up was there. We have not included that as part of the study, how we treated and what was the outcome.
Yeah,
Because
so
the,
from that angle, you have a one-point contact with the patient. So that makes it more of a cross-sectional study rather than a prospective.
Right, sir. The only thing I wanted to say was we took it at a point of time. The aim of this study was to detect rejection. So our idea was not to follow up these patients. Of course, naturally, whatever
I'm not-
rejection and
I'm
whatever
not
treatment protocols were there were followed.
I'm not questioning your, what I'm saying that the writing in the design of the study, I'm not saying that what you did was not appropriate. What you wanted
Right.
to do, you do accordingly.
Yes, sir. I understand what you meant, sir. Right. Your point is taken. You had asked me too many questions, so I don't remember the questions.
No,
If I can just
put a
answer one about the creatinine 1.5 milligram per deciliter for the stable graph patients. So if you look at it closely, it was less than 1.5, but it also had to be within 10% of their baseline best creatinine. So we know that some patients who may have older donors, the creatinine, even at best creatinine post-transplant, may be 1.3 to begin with. So we needed it to be less than 1.5. And also it has to be within 10% of their baseline best creatinine. And not only that, we also followed them up for 1 year and made sure that this was sustained and there was no proteinuria in these patients, simply because when we had a discussion within our own team and with our ethical committee, it was considered not ethical to biopsy those stable graft patients. So they were deemed to be stable graft function, probably no evidence of active rejection because the creatinine was not going up. But I completely understand. It is possible that they could have had subclinical injury, but with the caveat that within 10% of their baseline best creatinine was also actually included. And why we included this as a prospective study was because these patients were followed up for almost a year. And though we did not include follow-up data per se, these patients we were looking at what was happening to them over a period of time. Maybe we could publish that later in the future. But your point is well taken. The data that we presented to look at the diagnostic scores was a cross-sectional at one point in time that we looked at them.
No, I just want to comment on the serum creatinine value. You see, what you are saying is within 10% of the best creatinine. Now, many of the time in a post-transplant period, the best creatinine is not normal. So even though if you take within 10% of the best creatinine, it still may not be normal creatinine and the patient may have a chronicity and which may not have proteinuria of significant degree. So what I'm trying to say that because a marker which is being tested in this study has got a possibility of increasing in a chronic graft dysfunction also, the just keeping stable doesn't exclude that that patient was not having a health state where the marker will not increase. That is the only point I am making.
It is possible, sir. Definitely what is possible. But just those patients, I don't know. Maybe that's something that we must consider.
Many times in transplant patients, we should be little careful in differentiating stable versus normal graft. Because
that's exactly why we use the word stable, sir. That's why we said stable graft function rather than normal graft function. I think that's definitely a limitation of the study as well.
Okay, any other question? Narayan, you want to put any other question?
Sir, we have a question from the one of the attendees about the probe, whether the donor-specific DNA pool from the pool, does it represent a pan-India population and ethnicity?
Dr. Arvind can probably answer that because it's a
Yeah,
probe that he has developed.
So I had the SNPs developed from the population from, I think, Hyderabad down south. So I don't think that included any population north of Hyderabad. No.
So basically, it is from a South Indian population. And one other question which was there, I think from Professor Sanjeev Gulati sir, was if you are going to change the diagnostic thresholds, will the cost change?
Can you repeat?
If you are going to change the diagnostic thresholds, will the cost be changed? Will the cost be affected?
I think the diagnostic threshold is inherent to this platform. If we are going to use this platform, this is the threshold we would be able to reach. So basically the difference is, let's say the cutoff in our study was 0.26 and in TCMRs it was very, very low. It was almost 0.02, 0.04. At lower than that, we were not able to detect any donor-derived cell-free DNA. Whereas in the Western data, they were able to detect and quantify it lower than that and say this was the number. But still at that threshold, it did not differentiate between a TCMR 1A or a pyelonephritis or an ATA. So where they were able to say it is this number, but still we're not able to differentiate. Our platform said it is not at all detectable at that level, and that's why we're not able to differentiate. So even if we change the threshold in this, will it give us more clinical data? At the moment, no.
Perfect. Done. I think we are already reaching 9. So I request Professor Agarwal sir and Edwin sir probably to give some final points to the discussion.
I will say that you see in nephrology, biomarker are being tested for many clinical situations, whether it is acute kidney injury or whether it is a transplant. And because the current journal is in transplant, so I think transplant biomarker, both urinary and blood, is going on for maybe for last 20 years. But still, we haven't reached to the stage when the decision of clinical decision bedside for the treatment of the patient is still not based on the biomarker, and it still has remained the research tool or comparing or understanding the pathogenesis. But for patient perspective, still the biopsy is gold standard. And with the advancement of methodology of biopsy, automatic gun and ultrasound assistance, the statement that biopsy is a invasive test, I think many of us will probably not take that as a true. So we still, I don't know, in a clinical setting, more in India, tests like cell-free DNA with a cost involved and with a paucity of importance in surveillance. How much it will be useful clinically, probably time will tell. Dr. Edwin can recommend.
Yeah, your points are well taken, sir. We have seen it in AK also. These biomarkers don't help us to guide the management, but definitely they alert us to the possibility for a more closer follow. So in that way, cell-free DNA could be useful. But of course, as you mentioned, that one cannot base our treatment without a biopsy, and biopsy is definitely essential. But in a surveillance perspective, definitely it is useful. Definitely it would be useful. Yeah, I think the best way to take it forward is probably to get some ICMR funding and take it forward on a larger scale with many centers involved, with many populations, samples, so that we can have some sort of a guideline on this. Of course, it's going to take a long time and it is a tedious process, but somebody can take it forward.
Thank you, sir. I'd like to thank the panelists and all the attendees for having taken part in such an interesting discussion. And we hope to have you all next month also on the 3rd Wednesday. We will try to take studies which are pertinent to our population. So if that is it, we will end the discussion. It is 9 o'clock.
Thank you.
Thank
Thank
you.
you,
Thank
sir.
you,
Thank
Arun.
you.
Thank you, Arvind, and thank you, Harsha, for joining.
Thank you. Thank you, sir.
Thank you, sir.
Arvind.
Thank you, sir.
Thank you.